Hi everybody. Wow, this person is right up on my butt. Got out of the office early today. I need to take care of this mop that's on my head. This hair is getting out of control. I had a scary dream last night that my hair was like down to my rhomboids, my upper back, and it scared the heck out of me, and I tweaked my neck in my sleep, and I took that as a sign it's time to get a haircut. So here we go. Wanted to talk to you about, there was a lot of cardiovascular management today, so focus on cardiovascular health. As some of you know, and if you don't know, autoimmune disease increases your risk of heart disease, and heart disease, strokes, that's one of the big boogeymans that takes us out in older age. And so we want to be extra vigilant with those of you struggling with autoimmune disease, and make sure that we're crossing all of our I's and dotting all of our T's with your modifiable risk factors. There's different degrees of magnitude for which autoimmune disease increases your risk. I posted something a little bit, I think it was earlier last month, that stratified risk based off of what autoimmune diseases you have. Lupus led the pack, rheumatoid arthritis followed, some of the spondyloarthropathies, psoriatic, ankylosing spondylitis didn't seem to as much, but you've got some extra inflammation going on, and so we want to keep that in check, because inflammation is what drives cardiovascular disease and lipid peroxidation and foam cells and all that wonderful stuff that happens in the arteries. And so first are your risk factors, okay? So we ask about your family history. Has anybody suddenly died of a heart attack in their younger years or middle age? Get a sense of the wiser folks in your life who are more likely to have had a stroke or a heart attack. Have you had any events personally? Are you on a statin therapy? Are you off statins? Are you on aspirin for primary prevention, which is silly? Aspirin should really only be considered for secondary prevention. Do you have high blood pressure? Do you have diabetes? Are you overweight? Do you have chronic kidney disease? Do you have chronic lung disease? These are some of the things that are going to be the primary driving comorbidities of heart disease. Okay? Do you smoke? Do you drink a bunch? And then we get into the lab tests. So your cardiologist will usually do a lipid panel. It'll have your total cholesterol, your LDL cholesterol, the good and the bad, they say, your total to HDL ratio, non-HDL cholesterols, they might run triglycerides. They'll probably check a hemoglobin A1C with that. And I like to go a little bit further, but not too far. There's all these funky, exotic lipoprotein and NMR profiles you can do. I just look at one guy, and it's called the ApoB. I also look at the Apo-a. I'll look at a high sensitivity CRP. You've heard of CRP before. We check that a lot when we're considering inflammatory type issues and autoimmune disease, but a high sensitivity CRP, a myeloperoxidase, an LPPLA2, ApoB, LDL particle number, and Apo-a. Apo-a. So why all these other guys? Well, it turns out cholesterol itself may not be the culprit, and it's actually, there's still debate and discussion on this, the lipoprotein particles themselves that carry the cholesterol. And so there's an analogy I use for patients. Your liver makes these little lipoproteins. They're like taxis that carry cholesterol around the body, okay, to deliver the cholesterol, because we need cholesterol for making hormones and cell membranes and a lot of other functions. They drop it off, they come back to the liver, go through the gallbladder, end up in the GI tract. Some of them are recycled, and that process goes on over and over and over and over again. So anyway, if you just check a standard lipid profile, there's some fraction of the population, depending on what stats you look at, upwards of 25%, who could be overtreated or undertreated if you're only looking at a standard lipid profile. The cholesterols, because it doesn't give us, the standard lipid profile does not give us a direct sense of how many cars are on the road. Remember those taxis? And more cars on the road equals more chance of an accident, i.e. the higher your LDL particle count, the more cars you have on the road, okay? And there's further speciation we can do of those lipoprotein particles. And you got small little dense ones, and you got big fluffy ones. And the big fluffy ones are like slow-moving trucks on the road. The small little dense ones are like little Maseratis with some asshole behind the wheel who's speeding around. You got more small little dense ones, higher chance of an accident. So some people who have a really ugly looking regular cholesterol profile will actually not have that many cars on the road, and they end up getting treated with a statin and they're overtreated. Others will have a beautiful looking cholesterol profile, but when we look a little bit deeper, there's a bunch of little Maseratis with butt heads behind the wheel speeding around, right? So we want to run an ApoB and an LDL particle number. Oftentimes, you know, if you're a little strapped for cash or your doctor doesn't offer it, we can look at the ratio of the total cholesterol to the HDL cholesterol. So 200 divided by 50, or excuse me, 200 divided by 5 or 200 divided by 4, whatever that number comes out to be, should be somewhere between 3 and 4. And that's usually a good proxy for how many cars you have on the road. But just for added insurance, I like to check the other guy. Okay, and then we can treat you accordingly. Most of the time, it's going to be getting your nutrition straight, getting out the processed food, figuring out if you're somebody who's more of a carbohydrate phenotype or you're somebody who's more of a fat phenotype, meaning dietary fat, and then you fill in the rest with protein. It's pretty straightforward. And then if things are still not working so well, we might look at your thyroid or your iron status. We might use some supplements. One of my favorites is polycosanol. And if things are still not working, then we look for some of the more exotic things. Toxicants, gut dysbiosis. Okay? And if all else fails, then maybe we consider a statin or some other lipid-lowering therapy. So it's really important that you be aware of this. If you have an autoimmune disease, you're at higher risk for cardiovascular events on the basis of extra inflammation. If your rheumatologist isn't checking, your primary care should be checking. If your primary care is not checking, somebody should be checking. So make sure you're having your lipids checked at least once a year. You may be doing well on your medication, but you can use those lipids as well as a proxy for some extra inflammation that's not being controlled. So I'm almost at the barbershop. I'm going to shut up now. Everybody take care and be safe, and don't have dreams that you have super long hair.
When you see me, then
oh, Drake is so good.
I got enemies.
Happy Friday Eve.